So today I'm going to talk about one of the most intriguing topics in the study of psychosis and schizophrenia in particular, is the lack of insight. So I'm going to tell you a little bit about what does it mean, what is the prevalence of it, what are the reasons for it, and potentially how to improve it. This is a nice quote I found. The beginning of the cure is the wish to be cured. And it very much corresponds to the whole problem of lack of insight in psychosis. If anybody of you is familiar with the 12-step program, the first step is we acknowledge we are powerless over something. So the first step is to acknowledge you have a problem. Now, that's what the lack of insight in very general terms means, is the inability or inability, let's just say, to acknowledge that something is wrong. So first of all, let's talk about the idea of insight in psychosis. It's fairly new term. Up until the 19th century, the idea that someone is insane meant that they have inability to be aware. That was the definition of they call it madness or insanity. It meant that someone has a delusional thinking. So you were insane, meaning you cannot be aware of what's happening. And then there are all these shifts in the study of the self. If you're all familiar with William James, Freud, who talked about the consciousness. William James talked about the I versus the me. And all these new concepts emerged, the subjective experience. So these changes in philosophy and psychology, the introduction of these terms, the self, the consciousness, introspection, they brought this paradigm shift. So people moved from thinking insanity means not having the ability to be aware, to including subjective experience in the definition of insanity. Now, that's kind of in general terms how it came to be. So we have around 100 years or something like that of insight in psychosis, of talking about it, of the term insight in psychosis. Up until then, it wasn't even perceived as possible. 100 years ago, it came to be part of the discussion. Now, what is insight in psychosis? It sounds simple, but it's actually very complicated, and there's no consensus on what exactly it is. But this is one of the first definitions or papers that were published of lack of insight in psychosis. So this guy, his name is Louis something, I forgot his first name. He wrote this paper about the psychopathology, and he defined what is insight, right? He said, it's a correct attitude to a morbid change in oneself. Now look, correct attitude, morbid, and change to oneself. He said these four aspects, they require discussion. Now this was in the 30s. Discussion wasn't followed for many, many years. So up until the 80s, there was no structural way of talking about insight. Now, this definition, I think, captures really well the complexity of what is insight. So first of all, you have to be aware that something is going on with you, right? Now, the second part is that you have to have an attitude that is correct. Namely, you have to be able to say that this change that I'm experiencing is morbid, is abnormal. So these things, so lack of insight can be many different things. One can have no awareness whatsoever, right? There's no awareness that something is happening to the self. These people That's how I call it in my research. They lack the core, insight. This is what I call core insight, being able to detect what's happening in oneself. If one experiences, for example, voices, right? They say they hear voices, and they're unable to differentiate the voices as something external to them, or even say, this is my voice, this is not my voice, then they cannot go through the next step, which is to say, oh, this voice is actually abnormal. You know, regular people don't hear voices. So you can have people who have no awareness whatsoever. This is usually called in the literature anosognosia. We'll talk about it later. There's also people who have awareness, but I don't think it's a problem. So I remember I talked to this young guy and I said, oh, do you have any abnormal experiences? And he said, well, it's normal to me. I don't know if it's going to be normal to you. And I think to categorize something as morbid or abnormal or different, you have to be, it's also very much dependent on the culture, the norms, what is normal and what is not normal. So you can have an awareness, say, okay, I'm hearing voices, but it's perfectly normal. Or you can have an awareness, you can say, this is abnormal, meaning judging it, but you do not agree to the consequences. You don't think it's a problem. So when we talk about insight study, this is all mixed. It's all mixed together. Some people say it's this or that, and we can talk about, this is part of my research, but in general term, what we have to know is that lack of insight in psychosis pretty much says lack of awareness to the change and the inability to judge it. So it can be one of these aspects, it can be both of them. Okay, now there are two types of insights that the literature talks about. There is the clinical insight, which is more the traditional way of talking about insight. So when people say insight, they usually mean clinical insight, meaning all the stuff we just talked about, meaning inability to be aware to having symptoms or mental illness, or to the need for treatment, or the efficacy of the medication, or the consequence of the illness. All of these things that are related to the clinical state, the lack of them, it's called clinical insight. So for example, when someone says, I'm not sick, the doctor are trying to manipulate me, I don't need medication. That is an example for someone with lack of insight. Now, when I say lack of insight, bear in mind that it's not a binary, it's a continuous variable, so it can mean many things. Some people can say, I'm sick, but I don't need treatment, or they can say, I'm not sick, but I will take treatment. So that's the kind of structure it is. Now, there is cognitive insight. Cognitive insight is a fairly new concept that in 2001, the CBT guy, the guy who developed the CBT technique in the 60s, Aaron Beck, he came with this term, and he developed a questionnaire that aimed to assess insight in terms of the flexibility, the metacognitive skills of the person. We'll talk about later in more details, but these are the two types of insight we got. Now, the dimension of cognitive insight, so it has two different structures, this dimension, that they work together and they reflect someone's cognitive insight. So first thing is the self-reflectiveness, right? So it's the ability to question one's belief and thought. Someone who has no doubt about what's going on and how they feel, has no ability to contemplate, wait a second, maybe the fact that I think the FBI is after me, maybe I need to think about it. Maybe I can look at evidence. And so first of all, the ability to reflect upon one's thought, and then the certainty. Now, you can say, first of all, you're prepared to put a question mark, and then you're prepared to be proven wrong. This is what cognitive insight looks at. Now, even though it's called cognitive insight, what it actually measures is metacognitive skills, and it has its own set of training. You can go through metacognitive training, and it's actually much easier to A, measure, and B, to change. It's considered part of insight, but again, it's a very specific part of it. Mostly when we talk about insight, when just people say insight without anything else, they mean the clinical aspect of it. In the most simple way, one's awareness of being ill. Now, clinical insight, as I said, is much more elusive because it has all these different structures. So there are a lot of different ways in which you can measure it. And one of the problems of the current state of affair is that different studies define insight, clinical insight, in different ways. In some cases, it can be awareness to the need of treatment. So the first, in the 80s, in 1989, it was pretty much one of the first structured scales that were developed to measure insight. At the time, insight was defined as accepting treatment and attitudes towards treatment. Now, there is situations in which someone can say, I am sick, but I don't want treatment. So how would you describe it? Do they have insight? Do they not have insight? That's why, and that's what I'm trying to do in my research, is to promote more greater level of specificity. So when you say a patient doesn't have insight, what exactly do you mean? Do they not have the core, are they lacking the core sense of insight, meaning nothing is wrong with me, I'm perfectly okay, meaning they don't have awareness of the illness, or they're not aware of the social consequence, or they have symptoms and they cannot label them correctly. For example, a lot of the people, when you evaluate them and you say, oh, do you think there's anything wrong with you? And they will say yes. Okay, why are you here? They will say anxiety, for example. So they acknowledge that there is a change to the self and they label it, except that they label it in a much lesser terms. So it's a very large scale, and all of these together, they make the dimension of insight. Okay. Now, one of the most fascinating things about the study of insight and psychosis is how common this is. So between 50 to 80% of patients, they either completely lacking insight, meaning I don't need to be here, I don't know what you're doing, to partial lack of insight, to, as I just described, I don't need treatment, or I do need treatment, but I'm not ill. And so it's a very, very challenging part of the illness. Now, as I mentioned before, there are various ways. I just, as you can see, this is a picture of one of the papers I published. What I'm trying to do is a systematic review of all the different insight scales. What's the best way to measure insight? That's the question. Now, I can tell you I've been working on it for almost a year now, and I don't have a good answer. I think it really depends on what you want to predict, right? If you want to predict treatment adherence, then you will use the ITEC, the Insight and Treatment Attitude Questionnaire, the one that was developed in the late 80s that I described. If you want to do something very comprehensive and you have tons of time in your hand, you can, and you want to look at aspects of awareness to the illness. You want to look at the core level of insight, and you want to be able to predict just, I would say, outcomes in general is probably the SAMS, the scale to assess unawareness of mental disorder. That's a very long scale. It has 72 different items. It's very comprehensive. It's probably one of the best scales. And it looks at awareness of having a mental disorder. So one has to be able to say, I am mentally ill, or I have a psychiatric disorder, or something of that kind. And then the second thing is the ability to attribute symptoms to the illness. So if someone says, yes, that's true, I come to the psychiatric hospital because I have anxiety, then it's a misattribution of, it's mislabeling of the symptoms. Another thing could be that someone acknowledged they have symptoms. For example, I'm hearing voices, but they're not necessarily going to attribute it to schizophrenia. So this scale is very good and has been psychometrically validated, but super long. Now you got all these other ones. Again, these are all fairly been around for 30 years. The Birkhood Insight Scale, it's from the early 90s, and the Schedule Assessment of Insight. This one is self-report. So if you don't have a lot of time and you want to administer it or something very quick, then you can use that. Again, this one looks at 3 components of insight. So based on what you want to predict, or the reason, you have to ask yourself, why am I trying to evaluate someone for lack of insight? Based on that, you can choose the scale. If it's just to see if someone is aware of what's happening with them, just to establish a relationship between a patient and a clinician, there's also the items from different scales that you can use. There is the PANS, the G12, it's a very famous item. A lot of studies have been written about this one item. Now I want to talk about why is that in schizophrenia and psychosis disorders in general, so many people lack insight. What is the reason? Now, there are the same way there are various definitions to what insight is and isn't. There are a lot of definitions or theoretical frameworks to what causes lack of insight. So you got the clinical model, which basically means, what do you mean? It means you have schizophrenia, you're delusional. Of course you won't be able to tell that you are sick. So that's kind of the most basic explanation. Lack of insight is a symptom. It's part of the illness. Hence, we see it so often. That's one way of looking at it. That essentially, you have the person who is experiencing the illness has a problem with perception of reality. Now, one of the problems with perception of reality is perceiving that reality, that you have a perception of reality problem. And that kind of makes sense when you think about it. However, there are a lot of people who are psychotic and do have insight. So that doesn't explain it 100%. The other model is a neuropsychological one. So this mainly explains the lack of clinical insight. So it's due to cognitive deficits, for example, problem with executive dysfunction, or there are all kinds of impairments that are related to self-monitoring and judgment. So this model attributes lack of insight mostly to neuropsychological problem. And similarly, the neurobiological model also explains that it's with some kind of a brain mechanism. There's something wrong in the brain, in the prefrontal cortex, in the temporal lobes. The term that I mentioned earlier, anosognosia, it's the meaning means the inability to be aware. Now, the reason, the theory behind that is a person is unable to be aware of their illness in the same way that a person who's had a stroke is unable to see the opposite side of the brain. So if they got a stroke on the right, they cannot see anything that's on the left side. So the neurobiological perspective is very similar. It says the brain of someone with psychosis is incapable of being aware. Again, we know that there are people with severe schizophrenia and the worst psychotic episode, they can still tell there's something wrong with them. So it might be true for some of the cases, but not all of the cases. Another model is the psychological denial. This is kind of just the psychological term of, oh, I deny something that I can't cope with. So it's a coping strategy. So a person cannot tell themselves or acknowledge that they're ill because they're protecting their self-esteem, they're protecting their self-worth. That's one model. Now, the last model is the sociocultural theories. The reason it's quite related to denial model because it says that in a certain culture, when schizophrenia is looked, it has such a bad stigma, and it's for some people it's like a death sentence when you tell them schizophrenia. Then they can't acknowledge that because of the culture. The culture looks at it so badly, then they refuse to accept that. I think the truth is probably somewhere in the middle. I think it really depends. Some people, they have this lack of awareness to the point you cannot even converse with them. Like they just don't know what's going on with them. I remember specifically meeting with a guy. We met I was doing an evaluation. We met in the psychiatric hospital. And I said to him, do you think you have a problem? Why are you coming here? Nothing. I have nothing wrong with me. Okay. Do you know where you are? Yes, I'm in a psychiatric hospital. Why are you here? He says, I don't know. Now, the guy comes every week, right? It wasn't just one-off. Okay. Then I know he's taking injections. So I said, do you get any medication? He says, yeah, I take injections. I take long-term, he didn't say that, but I'm telling you, long-term acting injections for schizophrenia, right? He has no idea. Now, that's probably the most hardcore of lack of insight. And it's, in my opinion, it's probably the one that falls under the definition of anosognosia. So the whole idea of anosognosia is that they have inability to be aware. It's not that you can change it. It is what it is. But these people with that level of unawareness, they're not the majority. There are some of them. But for most people, there is some level of awareness, maybe to some parts, not all of them, but some parts. So, okay. Now, why do we even care about insight? The reason is anybody who's ever worked with someone with schizophrenia is very familiar with how frustrating it is. Remember what I said in the beginning about the first step is acknowledging you have a problem. Now, when you're working with someone who has poor insight, then first of all, it's almost like denial. I'm not sick. I'm just stressed, right? Then you have this distrust. It's very hard to form a relationship with someone who believes you're reading their thoughts or you're forcing them to be there. And there's also the lack of motivation. Why would I bother to go to therapy if there's nothing wrong with me, if there's not a problem? So for people who are not familiar with lack of insight, say a family member who experienced it for the first time, it's very, very frustrating. And sometimes people can take it the wrong way, like it's something that is against them, but it's not the case. It's part of the illness and it's part of the problem. Now, another reason we care about insight, apart from the fact that it's very difficult to deal with it and very difficult to engage in treatment. Insight in itself, as we've done a couple of studies in the lab. One of them was just recently accepted to Schizophrenia Bulletin. We looked at the level of insight at time of admission to the service, enrollment to the STEP clinic, and how and what happens in 12 months in terms of hospitalization. How can it predict hospitalization? Now, as you might expect, having insight was reduced in a very substantial way the odds of being hospitalized within the first year of treatment. And also they had fewer emergency room. So the length of the hospitalizations and the frequency of hospitalization was much better for people with high insight. Now, we also looked at trajectory of insight. How does it change? So we measure at time 1, we measure at 6 months, and we measure at 12 months insight. And apparently, for some people, it changes quite a bit. For some people, it got better. For some people, it got worse. But the only thing that really predict was the high versus low. Those who were stable high and those who were stable low, these were associated with worse outcomes in terms of hospitalization. Another thing that goes with lack of insight is medication adherence. So people who don't think they have a problem are less likely to stick to their medication. It's much better now when we have the injections, but because you can monitor it. But if someone is home and has to take it by themselves, then it can be very challenging. It can be inconsistent, and then in itself, it can create even a worsening of the situation. Also, lack of insight it makes it hard to communicate with people, to have a shared ground. If you think someone has schizophrenia, is not in touch in reality, and the other person you're interacting with them thinks their imaginary friend is sitting next to them, but you're the problem and you can't see it, it's very hard to form a relationship. So I'm not talking just in terms of therapeutic, but just being with friends and stuff like that. So all in all, having better insights is associated with better outcomes. However, there is one thing that's called the insight paradox. And studies report that people with higher insight have higher depression, higher suicide rates. So that's something to be taken into account. Now, there is a paper here, Insight and Suicidality, that my colleague wrote, and I was a co-author in it. She looked at suicidality and insight, and she found that what explains the relationship between depression and suicidality is depression. So it's true that insight is correlated with higher suicidality, also known as the insight paradox. But she found that what is explaining that relationship is depression. This is also just got accepted to schizophrenia research. Okay, now we talked a lot about how hard it is not to have insight and how hard it is to work with people who don't have insight, but not all is gone. This is kind of the bright side of things. Dr. Javier Amador, he's very famous insight researcher. His brother had schizophrenia, and the way he describes is that his brother never, even when he died, he never regained insight. And he's the one who came with the whole anosognosia model. Now, he developed a model that's called LEAP. It stands for something that I'll tell you just about. The idea is that you don't really have to have insight to work with people. Now, the model includes 4 stages. So first talks about listening. So listening without challenging the person who has a lack of insight. For example, say someone says, the neighbors are watching me. You do not argue, just nod. The next thing is to empathize, right? Show empathy for the patient's experience. So for example, I can tell you, I sat with a girl just recently. She looked very scared. And I was evaluating her for her symptoms. And one of the questions was, can other people read your mind? And she said, yes, other people can read my mind. And I thought to myself, this is terrible. She thinks I can read her mind. Would you want other people to be able to read your mind? So I felt really bad for her. And I said, and on this occasion, I promise you, I cannot read your mind. Anyway, when they report their symptoms, try to put yourself in their shoes and see what it's like to have this constant fear that someone is watching you or listening to you or targeting you. And I think when we actually think about it, it's quite easy to do. It's very, very scary experience to have psychosis. Now, you listen, you empathize, now you agree, right? Find something you agree on, right? Okay, you're not sick, you say you don't recognize you have a problem. Now, let's find something we do agree on. Okay, say you struggle with sleep. Maybe there is a way for you to us to agree on that we are both agree that you want to have better sleep, regardless of anything. And then, based on this shared agreement, you partner. So you collaborate on treatment goals. So instead of pushing for a plan or imposing what I think is right on a patient, develop a mutual goal that aligns with both the patient and the clinician or the parent or whoever supports the person. So, for example, let's work together on a plan that helps with your sleep and overall well-being. So this model helps you to work with someone with lack of insight. Now I'm going to show you a video that summarizes what I just described. Hope it's going to work. Let's see. Yeah. Can they hear? I hope so. Laura, can they hear?
I can't hear yet, no.
Hold on. How about now?
Refuses treatment.
Yeah, can you turn it up a little?
Coping with a loved one's refusal of treatment for a severe mental health issue can
Yep.
be a challenging experience. Often, caregivers, despite their good intentions, find themselves perceived as enemies rather than allies by the very individuals they want to support. Rather than dismissing this resistance as denial, it's essential to recognize that the person may be grappling with a lack of insight into their condition.
Sorry.
A common symptom known as anosognosia is a lack of awareness stems from problems with the frontal lobes of the brain, typically occurring in severe mental health conditions like schizophrenia and bipolar disorder. Caregivers play a key role by adopting specific communication techniques that foster a sense of partnership and friendship with their loved ones experiencing a lack of insight. Dr. Xavier Amador, clinical psychologist and author of I Am Not Sick, I Don't Need Help, created the LEAP approach after and published research on it successfully assisting his brother, who had anosognosia as a symptom of his schizophrenia, in accepting treatment. This approach aims to establish trust and lower resistance to help the individual find their own motivation to embrace treatment. The acronym LEAP refers to 4 key components of the approach: listen, empathize, agree, and partner. This foundational communication tool involves actively listening to the person with a mental health condition, working towards understanding their reality and perspective. Asking non-judgmental questions and reflecting back their thoughts contributes to an atmosphere of respect. It is also possible for the caregiver to learn different tools that will help them to know when and how to give an opinion, and to show humility by apologizing when necessary. Feeling heard and acknowledged paves the way for the individual to be more receptive to hearing advice. Recognizing and acknowledging the various emotions that may underlie a person's refusal of treatment, be it fear, insecurity, or anger, builds a bridge of empathy. It is important to normalize their feelings by letting them know that in their situation, anyone would feel the same. By understanding their feelings, caregivers can address concerns more effectively, fostering openness to discussions about their condition. Despite seeming improbable, finding common ground is crucial. Identifying shared facts and highlighting areas of agreement helps the person express reasons why treatment could benefit them. This phase allows for subtle suggestions without directly addressing the mental health issue. Even with a lack of insight regarding their mental health condition, it is possible for them to find a good reason to seek treatment, such as wanting to improve their situation by finding a job or engaging in specific activities. It will become the objective that both parties will be able to work towards. It involves establishing a collaborative partnership centered around the shared objective. By utilizing the points of agreement, the caregiver and the individual can work together to explore solutions that will contribute to positive changes for the loved one's mental health. While individuals with severe mental health conditions may perceive life differently, the LEAP approach emphasizes the importance of respecting and acknowledging their reality. It shifts the focus from arguments, education, and disapproval towards emotional connection, validating feelings, and expressing care and concern without imposing an agenda. The approach facilitates a dialogue that promotes problem solving and collaboration, fortifying relationships on the path to recovery.
Hold on. What happened?
I would texted you back.
Hold on, let me figure out the technology. Okay, I don't know why, but it seems like I'm missing a slide which is supposed to recap the whole thing. But we'll have some time for questions, but the take-home message is insight is very, very common in people with schizophrenia. And it's challenging for mostly the people around and the clinicians around them. But there are ways around it. And I think understanding what it is and why it happens and how to cope with that can make it much more easier to deal with. So that's all I got. And if you have questions, please go ahead.